ultrasound, get to see other clinicians work at different clinics and do that as well. So Dr. Wagner is with us today. He's an associate professor for clinical internal medicine, the director of the ultrasound program for internal medicine residents, is the assistant director for physical diagnosis for us. So y'all will probably see him a little bit more next year as well. So without further ado, if y'all would welcome me, or join me in welcoming Dr. Wagner.
Appreciate it. So I appreciate the opportunity to be here today. I'll do my best to make sure if you guys cannot hear me in the back that you just raise your hand, give me a wave or something like that. I like to give this talk. I've given various versions of this talk in various venues, a lot of times to general internal medicine doctors, but also to you guys as students when you first come in the curriculum. And I think it's important you hear this early in the year. How many M1s are here today? Most of you guys are M1s, and then some of you guys are M2s in the back. All right, good. I see a couple of familiar faces from physical diagnosis. That's good, good, good. So the reason I think that it's important that you hear this early is I think we do a phenomenal job of integrating ultrasound into the curriculum throughout all 4 years. But one of the things that sometimes I think gets lost in that process is kind of the why behind why we do that. All right, and I like the idea of an ultrasound interest group because you guys are really sort of the champions and ambassadors of our ultrasound program, our ultrasound curriculum, and who are taking it to sort of the next level. I'm very, very interested in teaching you guys. I think ultrasound in general should be taught, or ultrasound should, you get ultrasound exposure as a medical student no matter what. But the people that I'm very much interested in teaching are the people who really want to be taught, the people who really want to learn it. And so I think it's really important that you have a proper frame of reference as to the scope of what point-of-care ultrasound is and portable ultrasound is, and the spirit and philosophy behind what we're doing. That way, when you're doing your ultrasound labs, you sort of know the methods sort of behind the madness, and you don't just sort of put that into that category of essentially learn and dump, learn and dump. This is a skill set that you should learn now and get going for the rest of your medical career. Okay? So just some background in terms of this program. This program has been in place since at least 2006, and it's been sort of steadily growing over time. And I think that, you guys are very, very fortunate, very, very lucky to be at a place like this. Not all medical schools do what we do, but they are increasingly coming on board. And if you look at websites like the AAMC, you look at the AIUM website on medical education, there's multiple medical schools that are now integrating ultrasound into the curricula like we do. And I think you guys are very fortunate in terms of all the opportunities that you get here, and I really encourage you to take advantage of all the opportunities that you can. Because once you leave this institution, depending on where you go, you may not have any resources available to you from an educational ultrasound education standpoint. And so the man behind the curtain, the person, the founder behind all this is Richard Hopman, who's the former dean of the medical school and is now the full-time director of the Ultrasound Institute here. We have extensive experience with medical education and integrating ultrasound into it. And there's a number of papers that have been published sort of along the way. And it's just a tremendous team to be working for. You guys, like I said, are very fortunate to be here. So let's get started. Why learn ultrasound? Why use ultrasound? As opposed to any other sort of imaging modality in terms of any other things that we learn in medical school. One, first and foremost, is that ultrasound, it's safe. So unlike, what's the disadvantage of x-rays and CAT scans? Yeah, so the exposure to ionizing radiation. What's the disadvantage of just sort of putting needles into spaces and getting fluid back and testing and running a bunch of labs? it's invasive, you can cause harm, right? And so with ultrasound, it uses sound waves to create and generate an image. What we're talking about when we're talking about point-of-care ultrasound is the same technology that we use to look at babies, right? And there's no ionizing radiation exposure, and there's sort of theoretical mechanical effects, but there's really been no good studies that have shown, you know, when you're using the diagnostic type ultrasound in the way that we use ultrasound, that there have been any adverse effects, okay? So because it's safe, it's repeatable. We can do the same ultrasound exam on somebody sort of serially over and over and over again and not feel guilty about it, and also not expose sort of the patient to the same risk. The reason this becomes important is because, you know, if you look at my medicine service, the patients coming in who are admitted under our team, if you look back and you can see their imaging, you know, this historical imaging, it's not uncommon to be on an internal medicine service and have essentially, you know, have 50 radiologic studies in the last, you know, five years. And so that kind of stuff adds up over time. One patient on my service, you know, had recurrent small bowel obstructions. He's in his 30s and he's had 30 CT scans in the last 5 years. So the other reason I like ultrasound in terms of the medical education component, and because I really like physical diagnosis, is unlike when you look in the back of the eye and you say, oh yeah, Dr. Wagner, I see the back of the eye. Yeah, I totally see it. I can't see if you can see it, right? You guys have tells that, you know, say that you don't see what you say you're seeing. But I can't subjectively share that experience with you, right? Whereas when we look at the ultrasound of the eye together, and you're saying, oh, I see the back of the eye, I can see what you see. We share that same experience. And so it's nice and it's shareable. The other thing about ultrasound is that you can visualize in real time. When ultrasound first came out, you used to have to take an ultrasound picture, and it was like snapping a chest x-ray. It was kind of like you would get that picture, and then it would process, and then later on you would view it, right? Just like a CAT scan. You get that picture, and then later on you view it. With ultrasound, as it's happening, you can be watching. And so it makes itself very useful for doing things like guiding procedures. When you're placing a needle or a tube or something like that into a patient's body, you can see everything that's happening right there before your eyes. And then also, as you're, you know, imaging things like musculoskeletal ultrasound, if you're interested in function, you can have them sort of range their joints, move things around. You can see muscles contract. You can see tendons move around. So it's very dynamic imaging. And then the other thing is it's just cost effective. It's a lot cheaper than, say, an MRI. And if you look at some studies looking at, you know, real good experts with musculoskeletal ultrasound looking at the shoulder, in some cases, they're just as good as having an MRI, but it's not nearly as expensive. So with that in mind, you kind of wonder, well, why now? Why not 15, 20 years ago, and why not in another 10 to 15 years? And I think there's a million reasons that I could give you, so I'm only going to try to pare things down and only do a couple. So one is, as you do your physical diagnosis course, as you start learning about, you know, your skill sets with your hands, with your stethoscope, all your traditional modalities, you're going to find that there's this growing gap between what you can confidently diagnose using your traditional exam skills and what you can diagnose using a bunch of advanced imaging and a bunch of tests and things like that. And I think that it's important to know that as the standard of medical care kind of evolves, where people want the best, not only for themselves, but say for their family. They want the best medical care that they can get. There's an expectation that that be a lot of times technologically driven. And they're not going to be, even if the answer to the clinical question is best solved by your ability to use your brain and interpret sort of the data in front of you, then you just sort of examining them with a stethoscope a lot of times psychologically is just not going to cut it for people. And so there's also this medical legal concerns about missing, you know, a diagnosis. And I think that, you know, this big gap that's evolving is helped bridge by using point-of-care ultrasound. It helps take our physical exam to the next level, bridge that gap. So this common question comes up a little bit, usually not with medical students, but usually by people who have a lot of exposure to traditional ultrasound. And they say, well, we don't have time to do, a formal ultrasound, say, of somebody's liver in my office practice. And that's because they're conceptualizing ultrasound in the way that it's kind of grown up in the United States, where a physician sort of thinks about what tests they want to order. And they say, okay, I want to order an ultrasound and look for gallstones in the gallbladder. And then they send the patient away. And they have a technician perform the ultrasound, who then turns those images over to a radiologist who interprets that ultrasound, right? So the technologist performs it, the radiologist interprets it, and then that report gets generated and sent back to the physician who's actually taking care of and managing the patient. And that fragmentation in terms of the diagnostic process in some ways is beneficial, but in other ways is not. And for those ways that it's not, point-of-care ultrasound helps sort of really streamline that process. Patient comes to me complaining of right upper quadrant pain, and I, in my mind, say, I wonder if they have gallstones. I say, lift up your shirt. We're going to take a quick look and see, okay? And then we have that answer within 2 to 3 minutes right there in the office, okay, as opposed to that delayed in care. But also, I get to see, well, say they have gallstones. Is it the gallbladder that's the problem, or is it the liver? Sometimes, like, the liver gets expanded and swollen and becomes painful. And so the gallbladder itself, as we're pressing on it, is not tender, even if they have stones. Whereas the rest of the liver, as we're pressing on it with the probe in my hand in front of the patient, is tender. And so we know that even though the gallstones are there, the patient may not be best benefited by having that gallbladder removed. We need to actually work up, why is their liver big and swollen, okay? Which you might not get if you're the patient performing the ultrasound and you don't have that clinical background and you're not talking to the patient and getting all that information. So not only does that help us with our diagnostic abilities, but it also helps us really improve how we manage the patients. So when we're treating them, as we're treating them, we have the opportunity to guide our therapies, either with procedures or as we're giving therapies, we can monitor how the patient's responding to those treatments over time. And that role of the general internist, where I come in, versus the ER and the critical care folks, is as I see the spectrum of the patient. I see the patient from when they're really, really sick, but also as they kind of get better and then move into the outpatient setting, and the other way around, from the outpatient setting, getting sick, into the inpatient setting and see the spectrum as they get worse, right? So that spectrum of disease, ultrasound represents a very, very nice sort of longitudinal monitoring tool. And so conceptually, this is just another physical exam tool. And a lot of times we get really excited when we're in point-of-care ultrasound. We talk about, oh, we're going to revolutionize the way medicine is practiced. And it's really not a revolution. It's just the natural state of affairs where we now have a better tool that has evolved over time. And now we have, just like a stethoscope or an otoscope or an ophthalmoscope, and now a panoptic, right? Panoptics are way better than an ophthalmoscope. And now there's a device that'll plug right into your smartphone that you can put against somebody's eye and get a fantastic view of the back of the eye. Right? And so this is just like that. We're developing essentially like a better physical diagnosis tool. And so if this is what your concept is of an ultrasound machine, right? This sort of Soviet era, takes up half of a room, giant machine that takes like, a huge amount of strength to move around. We need to update that concept of what an ultrasound machine is, right? There are now pocket-sized devices. There are tablet-sized devices. They give fantastic image resolution. And there's now even devices that plug directly into your smartphone and run on an app, okay? There are now devices just recently released that don't even require to be plugged into anything. They transmit wirelessly. And it won't be long until the future where you have essentially these devices that go directly to a heads-up display. And you can essentially say, Siri, bring me up a image of a gallbladder with stones in it. Searches the internet, shows you some images with gallbladder stones. Then you say, Siri, capture an image of this person's gallbladder. And then it takes a picture based on the probe that you hand sort of transmit it. That technology is sort of coming. The use of AI and the ability to kind of gather a lot of computer information and integrate it with the ultrasound is being developed. And things like, there's a stethoscope that you can kind of have an EKG plugged in with your stethoscope, right? And so there's devices that are going to, integrate, EKG, stethoscope, ultrasound findings, pulse oximetry, all those sorts of things are going to be, at your fingertips in terms of a diagnostic skill set. And so with the pace of technology rapidly developing, if you don't learn how to use this kind of tool now, and you wait until you're already practicing medicine, you're going to be way behind the curve, and it's going to be much more challenging and difficult for you to learn it in the future. And so, taking advantage of all this technological information, I find that surprisingly, the amount of lecture time and formal education that you need with learning this nowadays at this time is much, much less than it probably was, when this curriculum first got started in 2006. You have amazingly fast internet connections. You have an abundance of free open access medical education. And you do not technically really need a giant, formal curriculum for you to at least learn very basic ultrasound. This is, essentially for everybody. And with that comes a lot of increased understanding of, ultrasound artifacts and things like that. You look at this and you say, I have no idea what the heck I'm looking at. But what I'll tell you is over time, as you practice your skill set with some of that education, you could look at that image on the left and you say, that person has a pneumothorax, that person has a collapsed lung, and that's 100% specific for that finding, right? And then this person here on the right, looking at ultrasound of their belly, I can tell you with very high accuracy, that person has a perforated bowel and has free air inside their abdomen, sort of moving around inside their abdomen. And it's just all a matter of kind of having an increased understanding of some of these ultrasound artifacts. And that comes from a lot of research that's been done. Who here knows about the NASA ultrasound program? Right? Who here has seen at least Apollo 13, the movie Apollo 13? A couple of people, right? When Ed Harris is like in the room and he's like, all right, people, we got this many watts, and you're going to have to figure out how to run this entire, spacecraft on this many watts, and they're all smoking a bunch of cigarettes and drinking a bunch of coffee, and they put their giant eggheads together, and they figure out oh, this is what we got to do, right? There's only one diagnostic imaging modality thing in the International Space Station, and it's an ultrasound machine. And so a lot of the research that we had in the early 2000s that came out of this, like ultrasounding for pneumothorax and things like that, a lot of that was helped, refined, and developed by people like at NASA, physicians working in partnership with NASA. And so here are some articles that have actually been published from the International Space Station. It's pretty cool, right? And so as you can imagine, when you start getting really smart people involved, really enthusiastic people involved, the application list of point-of-care ultrasounds is going to move way beyond just kind of looking at, babies and hearts, right? It's going to expand to pretty much everything from head to toe. And the challenge nowadays is for me to actually develop, curricula that are, not too overwhelming, because it can be like drinking from a fire hose if you try to learn it all at once. So since there's so many applications that you can learn, it makes sense that everybody learn this, right? Because it doesn't matter if you want to be an anesthesiologist or an OBGYN or a pediatrician or a surgeon. There are applications of point-of-care ultrasound that specifically pertain to your field that you can then help advance as you move along in your career. So let's go over just some specific examples, because sometimes it's like, what are you talking about? So say you have somebody who comes in, they have head trauma, they're altered, and you're concerned that they have increased intracranial pressure, right? And you want to assess their normal light reflex to see whether or not they have a blown pupil. How many people think that you can see the back of this guy's eye? Right? How many people think you can see his pupil? Probably very few, right? But you can use ultrasound, put the ultrasound probe over top of the eyelid, and take a look, shine the light in this guy's eye here, and then what happens is causes a consensual reflex, and you can see that that pupil constricts very nicely in response to that normal light reflex. And you say, oh, he doesn't have a fixed blown pupil, right? Or say you have somebody else comes in with altered mental status and you're concerned about, high pressures in the head. The way that you would traditionally monitor somebody's intracerebral pressures or intracranial pressures is you would put in a specific invasive monitor and see, are they actually having pressures increase in their brain? It's not something you would want, right? You can actually put the ultrasound probe on the eye and look at the optic nerve as it travels from the brain to the eye. And that sheath, that connective tissue that surrounds the optic nerve is actually contiguous with the dura mater of the brain. And so as pressure increases inside the brain, that transmits down the optic nerve sheath, and it causes this to spread and dilate. So you can then measure the optic nerve sheath diameter and get an idea of what somebody's intracranial pressure is. And there are NASA folks that have looked at pigs and done this in pigs and gone up and down and things like that. So if you're squeamish about that stuff, never mind. But anyway, so if you have somebody who comes in, they're tachycardic, they got a high respiratory rate, they have altered mental status, and they look very sick. Sometimes the question is, do they have a blood clot in their lungs? Okay. And a lot of times the quick response to that is, quick, send them to CAT scan. Get a CT CAT scan, get a look at the arteries in the lungs, and let's make sure they don't have a blood clot in the lungs. Well, contrast from a CAT scan contains a tremendous amount of iodine. And so if your problem is not a blood clot in the lungs, if your problem is that you have a very hyperactive thyroid, and that's why you have tachycardia and tachypnea and altered mental status, then once you go and get that big iodine load in the form of contrast, that can actually make your hyperthyroidism precipitously worse, and also, potentially mess up sort of downstream testing later on. But here you can look at this person's thyroid and know that they have normal vascularity of their thyroid, normal thyroid, versus this person who has an incredible vasculature of a very enlarged thyroid, and immediately diagnose them with the clinical findings of thyroid storm. And I have a colleague of mine who works in the emergency department, and he's had times where he didn't have the thyroid labs. You say, well, you just get thyroid labs. Sometimes you don't have access to it, and in this case, in the emergency room, he didn't have access to it. But he was able to immediately diagnose hyperthyroidism and thyroid storm within minutes at the bedside, even before the lab tests come back. Okay? This is a patient of mine who came into my clinic complaining of pain after a fall. And a lot of times, the interaction you have with a patient is just helping them find the answer. And so the traditional thing is well, you have pain, you probably fractured a rib, there's nothing that we do for that anyway, we don't cast ribs, we don't put in screws or anything like that. So, here's some pain medicines and just sort of ride it out at home. Well, a lot of those patients will essentially kind of go, I want a different opinion. And then they'll seek other medical care and things like that. And not this person, thankfully, but I've heard of this happening several times where people see several different medical providers, to include going to the emergency room, because something's wrong and they don't have a diagnosis yet. And so in this case, you say, put this ultrasound probe where it hurts the most. Okay. Right there, that's the spot, right there. Okay, got it. Line things up. And then this is the normal rib cortex here. And then this is the spot where it's most tender. And you can see there's a giant rift here between the two cortices. And if you twist the probe in sort of long axis instead of the short axis and look at the whole rib on its side, you can see this very nice step-off deformity, which his x-ray, which he had had by another provider, x-ray was read as negative, no acute rib fracture. What's the sensitivity of x-ray for rib fracture? What do you guys think? Do you think it's a good test for rib fracture? Yeah, it's a terrible test for rib fracture. It's less than 60% sensitive for rib fracture. Whereas if I show you this, yeah. Who here is uncomfortable and makes it wince just by looking at that, right? And so that's not subtle, right? And that's something you can diagnose right there in the clinic. The patients can help you. And then you give that patient an answer, and then they now understand their disease process better, and you have a better sort of rapport with them. And so it's not just rib fractures, it's not minor fractures. What about, the person that, comes in, especially the kid? Who wants to give a kid a bunch of x-rays, right? They can come in, they can have a deformity. You can not only diagnose the kid's rib or long bone fracture with an ultrasound machine, but then you can use that same ultrasound and do a local nerve block so that the arm then becomes numb, but you don't damage any associated vasculature or anything like that associated with it. And now that it's nice and numb and they're not feeling the pain, you can very nicely do a very easy reduction. And you don't have to expose them to conscious sedation, which can be generally risky. And you don't have to ever expose them to radiation. And then you can check your alignment with the ultrasound, make sure things are lining up before you then do your casting and stuff like that. So this is not just for us generalists, this can be for orthopedic docs and ER guys too. And this can be happening through the patient's course. You have somebody who comes in with a red swollen limb, it's painful, it hurts, they're wondering what's going on. Well, you can use ultrasound to distinguish whether or not it's a underlying abscess, a fluid collection there, versus just a bunch of soft tissue edema and suggestive of skin infection like cellulitis, or even, in the right clinical circumstances, a intramuscular hematoma. You have a patient who comes in, has seen multiple providers for fevers and not really knowing what's going on, diagnosed with a URI, and then a UTI, and then pyelonephritis. And you come by, and she's had several different sort of encounters with the medical field in different settings to now include the emergency department, and this is emergency department number 2. She gets diagnosed with pyelonephritis, but she's looking pretty good, so let's just give her some antibiotics and send her on her way. Well, this is a normal view of somebody's right kidney here, and then this is her kidney here. And so you can see these things do not look like each other. There's a big, large, black space that's inside the collecting system of the kidney here. And so this is what we call hydronephrosis. It means that there's a blockage somewhere between the urethra and the kidney, which is causing backup of urine to expand into that collecting system. And you can see here that these little hyperechoic things with little shadows coming off of them are stones, kidney stones. And so this lady had an obstructing renal stone that was infected. And so what's the cure for a focal collection of fluid that's infected? a lot of times it's relieval of that obstruction. And so this is in a way that without using any radiation, you can essentially diagnose somebody's ureteral obstruction and help treat that infection. And so this lady actually ultimately got septic. She was admitted because of this finding. A urologist was consulted to help relieve the obstruction. The urologist said, oh, well, we'll wait until the morning. She got septic overnight, and then they had to come in sort of urgently and then relieve the obstruction. But, you know, I think this is one of those things where it can not only get the right diagnosis. Imagine if we had done this at the primary care office side, way advanced of her coming to the ER, but also sort of better triage and better understand exactly what the diagnosis is, because how often are we wrong in our, you know, assessments? Probably more frequently we'd like to admit. So say you want, anybody interested in OBGYN? Yeah, maybe a little bit. And so, you know, you guys were, you know, the very, very beginning people, early adopters of ultrasound technology. Look at babies. But wouldn't it be cool if you could use that same technology to diagnose things like, you know, why does my patient have cough and shortness of breath and fevers? You know, a lot of times you hem and haw about, you know, what to do, whether or not to get an imaging study and things like that. You can use that same technology you already have in your office and now look at, say, the lungs. And so this is in a pregnant patient who unfortunately, ultimately, to get this diagnosis, had to have a CT scan. But how awesome would it have been if we were able to put that ultrasound probe and sort of see right on the lungs, you can see this consolidated lung. It kind of looks like liver, surrounded by just a small amount of effusion. And you can see that pneumonia and diagnose that pneumonia without any radiation exposure. So one of the old sort of things about, you know, well, you can just get an X-ray. And sometimes an X-ray will show you what you need to see, and sometimes it won't. And so in this particular case, the X-ray just shows a pleural effusion. But what's abnormal about this pleural effusion is that if you look up in the chest, kind of looks like a Lord of the Rings spider or something has gotten there first, right? Laid a bunch of webs. And so all of that is fibrin stranding, and it's all inflamed, and this is what we call loculated pleural effusion. So it's not just simple fluid inside the chest. It's actually a complicated collection and network of fluid that if you put a needle in and drain it, say based on an X-ray, it's not going to get any better. And so this person needs a chest tube have those medications infused to try to break those lytic things down, or even chest surgery to kind of break up those loculations. This happens all the time where we admit patients with, you guys know what COPD is? Emphysema, chronic bronchitis, right? And so they get a history of COPD, they come in short of breath, and they're hypoxic, and they say, well, you know, this is another, you know, COPD exacerbation. But if you look at this person's heart, this is the left side of their heart, this is the right side of their heart. Do you guys know which side should be bigger? Yeah, the left side should be bigger, right? And so this is the right side of their heart. The right side is huge, the left side is small and underfilled. And so then you say, well, do they have pulmonary hypertension? And in somebody who has no prior history of pulmonary hypertension, then you might want to go down and look at the blood vessels in the leg and sort of see if you can compress those veins. Does that vein compress normally? You think this is the vein right here, watch this. Does that compress all the way? No, it doesn't, right? And so you can even see without even compressing, there's something in that lumen. And so this is a blood clot sitting in the veins that's now, you know, presumptively pieces have broken off and traveled to the lung and caused blood clots in the lung, causing strain on the heart and low oxygen levels. And so you can diagnose this right away. And this happens all the time, where you're not sure what the intravascular volume status of the patient is. You know, should you give fluids or should you not give fluids? Should you be removing fluids? And on traditional exam, that is notoriously difficult, and very often we are wrong. And so in this particular person, this person was diagnosed with volume overload because everywhere they had edema everywhere. But where the fluid matters, in the intravascular space, you can see this is their inferior vena cava, you know, the biggest blood vessel in the abdomen, right as it goes back into the abdomen, into the heart. It's teeny tiny. We like to call this the sliver in the liver. It's a little teeny tiny vessel. It means their intravascular volume is incredibly low, right? And so even if they have crackles on exam and edema everywhere, the answer to that person is not take away fluids. And in this person, that's what happened. They got a big slug of what we call Lasix, which is a fluid pill that helps remove a bunch of fluid from your body. And what do you think happened to them? What do you think happens when you lose your preload to your heart? You think your heart continues to pump blood? You don't have any blood to really pump. There's no circulating blood volume, and so this person coded and had to be resuscitated. What do you think a bunch of epinephrine does? You know, the medication we give that constricts blood vessels to bring blood pressure back up. What do you think a bunch of that does? Not a lot unless you restore intravascular blood volume, right? And so I think the ultrasound will actually make its way. Do you guys all learn ACLS and BLS yet, or does that come later? Yeah. So at some point, you're going to have to learn advanced cardiac life support, and I think you'll see, this is already suggested, but I think you'll start seeing this work its way into the guidelines. Why is this patient sick and dying? And you're going to use ultrasound to kind of figure that question out. And we'll do this as the last one. You know, this is a representative clip from a patient who was in the ICU, and they had been diagnosed with septic shock. And septic shock, when they have a very severe life-threatening infection, causes you to lose vascular tone, and your blood pressure just plummets and drops. And so you need special medicines to help increase the blood pressure, give fluids, those sorts of things, resuscitate that patient. And in this person, they were getting all of those things, treated with antibiotics, blood pressure medicines, all those things, try to save this person, but they were not doing well. They were dying. And they had all sorts of markers that suggested they were going to continue to get worse. And so the critical care physician that then took over this person's care at a critical time, part of his routine is to examine the person's heart, every person who has shock and hypotension, to examine their heart and help figure out why are they in shock. And he saw this. Is this consistent with septic shock? Now, even if you have no ultrasound experience, you can see that this is a heart. It's moving around. And then if you know that just fluid is black, you can see that black fluid surrounds this whole heart. And once you just have some basic, very basic stuff, by the time you get done with graduation or your first year medical school, you will be able to look at this image and go, that's not normal. And then what this person has is a condition called, tamponade, where that fluid that surrounds the heart essentially squeezes the heart, and you can't fill the heart. And that's why this person was so sick. So the answer for this person was not all those medicines or any antibiotics. The answer was to put a needle into this space, drain that fluid. And that's what they did. And that person walked out of the hospital. And so my challenge to you is this, don't let anybody who has something like this, something as obvious like this, at this institution where you have a tremendous amount of ultrasound resources, a tremendous amount of education available to you, don't let somebody like this be under your care and die, right? That's what we're trying to prevent. So perceptions are really important, right? When you first learn ultrasound, it's very, very easy to think that you now have magical powers. And you can sort of call up, like a bunch of, just diagnoses at your whim. But what you will find is when you first start learning ultrasound, especially when you come on the clinical services with me and you're running around scanning patients, what you will find is if you do not practice beforehand, you will feel lost, and it will make you feel even more lowly and pitiful as a medical student, okay? And that's not the goal. We want to empower you, right? But you can't expect to wear the wizard hat and not do the work beforehand, okay? And so another thing is that when you say, you know, hey, I can look at these two images here, and in my patient who has right-sided chest pain and hypoxia and things like that, I'm going to look at this and say, hey, I'm concerned about a pneumothorax in this patient. If your people around you are not familiar with ultrasound, it's very easy to kind of look at these images and be like, what the heck is that? What are you doing? I don't like what you're doing, and be sort of leery and suspicious of that. So we realize that even though ultrasound at this institution is very big, and it's not necessarily for everybody, and you will encounter some resistance. So it's important that you're good ambassadors about using ultrasound in medical education. There's lots of concerns about us teaching you ultrasound, okay? There's a lot of concerns about it. And I can go over a number of them. But we can pretty much address most concerns. One of which is that, you know, you're not going to be nearly as accurate with the ultrasound machine as, you know, if you do a fellowship or you have extensive exposure. And my argument is this. My argument is that currently the standard is, you know, a certain set of skills that we teach you in terms of physical diagnosis. And it gets you to a certain point. And that certain point is probably pretty low. But if we give you a better tool, then we can raise you up. And so no matter what level that you're at with this tool, we can help you become better. So why medical students? One, you need a lot of time to learn this skill set. You can't learn this just by, coming to one course or something like that. It requires practice. It's just like learning a musical instrument. It's just like playing a sport. It requires deliberate practice, and it requires time. You learn a little bit, you forget some. You learn a bit more, you forget a little bit less. You learn a bit more, and then, you know, it goes on and on. And the other thing is that you guys are now in what I like to refer to as like the pluripotent stem cell phase of your, you know, medical education. You could differentiate into anything at this point. Sky's the limit. But how good would it be if I was able to give you guys a tool that you could then help evolve and push forward in the specialty of your choice? And I think that's, you know, really the goal. Rather than get kind of too frustrated with things, it's important that we just sort of light a candle rather than curse the darkness, right? So there's this great podcast. Who here listens to podcasts? There's a great podcast you're going to want to get involved in. It's an ultrasound podcast. Their slogan that they like to say is, you know, making horrible doctors decent and good doctors great. And I think there is definitely some sort of truth to that. But you want to actually be cognizant of the dangers of going too quickly, too fast, and without supervision. And I think it's important that if you are the type that's very, very motivated, that you really take advantage of that and move forward. So obviously the next step is just to be as involved as possible with the ultrasound interest group and get involved more than just the formal curriculum. Help improve the formal curriculum by giving good, positive, and constructive feedback to make it better. But you need to be the agents of change. You can't just rely on things to happen. You're responsible for your own medical education, not me. And so be involved with the interest group and then make the interest group. That's where you guys have real power because you can make that what you want. So that's the interest group website, still up and running, still going. And there's another good ultrasound interest group created by somebody named Jen Cotton, who's just a phenomenal med student and now a phenomenal resident. What she's done with kind of helping the student movement move forward, I think is really, truly admirable. And I think you guys could easily do something like the work that she's done. There's a Society of Ultrasound and Medical Education. We try to send some students each year. And then there's to the annual conference. There's a lot of great opportunities for you as students to be involved and have your voices heard. There's even now a national ultrasound interest group with AIUM. Very strongly encourage you guys to get involved with that and help that move along. We've had Ultrafests here, and they've had Ultrafests sort of around the country. It's a great way to kind of help connect with other medical schools in terms of regional little competitions and games and learning opportunities. And so I think probably the most important thing, and I'm going to get out of Dr. Brett's way here, is that you need to show that you care. You need to be engaged in the curriculum, and you need to be engaged in the ultrasound interest group. And through that, be a role model to other people around you. Help bring other people along with you. Be involved, and then be enthusiastic, but also know your limits, okay? I would trust Dr. Brett with his clinical brain and his stethoscope way more than I would trust any of you guys with an ultrasound machine, okay? So recognize the potential power that's there, but also sort of know your role, be respectful, and kind of be a part of things as opposed to kind of an antagonist or a fly or something like that. So with that, I thank you guys very much for your attention. I invite you guys to be involved, and I think it's a really exciting time and potentially a really bright future. So thank you guys very, very much for your attention. Reach out to me if you have any questions.